Hi, my name is Dr. Emelia Bachman. I'm with the Delaware Institute for Reproductive Medicine. We are part of the Boston IVF Network, and I'm going to talk to you today about intrauterine insemination, or IUI, and in vitro fertilization, or IVF. We'll start with intrauterine insemination, or IUI. What does this mean? This means that we are taking sperm and we are placing it in the uterus close to the openings of the tubes. So who is a good candidate for this procedure? We have many patients who would be candidates for this procedure. Most commonly, women who are single or women who are in a same-sex relationship often use intrauterine insemination. They would obtain donor sperm either from an anonymous or a directed donor, and that sperm is washed in the lab and placed in a sterile catheter and then gently placed through the cervix up near the openings of the tubes at the time of ovulation. We can also use intrauterine insemination for opposite sex couples in which perhaps there is a mild male factor where there's a mild abnormality of the sperm. There's also merit to using this when there is some sort of sexual dysfunction as well, and couples are unable to have penetrative intercourse. We can also use this when patients have either ovulatory dysfunction and they need medications to ovulate and they're not getting pregnant with intercourse. Or there may be couples who have what we call unexplained infertility, where we know that there is an issue there, but all of their testing is normal. And typically we give the female patient a medication to help induce ovulation, and we time that insemination with the ovulation as well. We do need to make sure that there are a few things that are normal for all these patients. We want to know that at least one tube is open, preferably both, but you can get pregnant with one tube with intrauterine insemination. We also want to make sure that the uterus is normal, and we will do this in your testing beforehand. Typically what happens, this treatment will start with a menstrual cycle. We give you these instructions in the office, but we have you call with the first day of the menstrual period. For patients who don't have regular periods, we can also just bring you in and check labs and ultrasound. And then for some patients, we may choose to use their natural cycle, and other patients we may use a medication. And that will be a discussion between you and your doctor. Then we monitor the growth of the follicles, right? What is a follicle? A follicle is a fluid-filled structure that has the egg inside. So we do blood work and ultrasound monitoring to know when is the appropriate time to do the insemination. And sometimes we use just the lab work, and sometimes we may use a medication to induce ovulation, what some people call the trigger shot, or an injection to help ovulation. After that, we will then time the insemination. Again, we put a small speculum in, and we put a sterile catheter that has that washed sperm, whether that's from a partner or from a donor sperm. And it doesn't hurt. It's sort of like a pap smear. We gently place the catheter in. Sometimes we have to use an ultrasound guidance on the abdomen, and we release that sperm near the openings of the tubes. Then we wait for a pregnancy test. So typically, you would talk with your doctor about how many cycles of this would be appropriate for you. So now, when would you do IVF, or in vitro fertilization? So for some patients, it's important that we move directly to in vitro fertilization and not wait to do any inseminations. And in these situations, they're patients who have blocked tubes, patients in which the male partner has very low sperm. So that's important to know. Sometimes when the sperm is of a really low number, the IUI success is very low. So we would recommend IVF. Also in patients whose partners actually need maybe a testicular biopsy or sperm that's retrieved from the testicle, that is where IVF is also indicated. It's also indicated when Patients are trying several inseminations and they're not getting pregnant. So often it's better to move on to IVF, which would be a much higher success. I also recommend this sometimes in patients who are older and time is of the essence. It may be smarter to move directly to IVF. But again, there may be situations in which you want to talk to your doctor about all your results and what might be best for you. We also do IVF when we are doing fertility preservation for patients who are either undergoing cancer treatments or perhaps who are planning to save eggs or embryos in there, for future use. So these are also patients who are really good candidates for IVF. Also, patients who may know they have a genetic condition that they want to test for and prevent that from being passed on to the child. Another reason we may do IVF is in same-sex couples who may want one partner to use her eggs and another partner to carry the baby. And that's IVF is indicated for that if the other partner would like to carry. And also, we would do this for same-sex male couples as well, where they have a donor who goes through the IVF process. And then the embryo is then put into a different gestational carrier as well. So let's talk about the steps of this. What happens? I like to talk about IVF and compare it to the natural menstrual cycle. So in the natural menstrual cycle, out of all the eggs you have, a group of eggs gets pushed to the surface every month. This is called our antral follicle count. And under the control of FSH, follicle stimulating hormone, in a natural cycle, one egg is chosen and the rest die. So in IVF, we're using injections of the same hormone that comes from your brain, FSH, and we're giving that to the patient for about 9 to 14 days. And so we're following them. And instead of maybe one egg ovulated, we want many eggs to ovulate. Many patients ask me, how many eggs am I going to get? Of course, that depends on a patient's age, their egg reserve, what that antral follicle count is, and everyone can respond differently in a different month. Each month, we have a different group of eggs. So the purpose of this is to get many eggs to grow. And so now, different from IUI, we're getting more eggs, and we can actually take the eggs out of the body. And instead of hoping egg and sperm meet in the tube, hoping they fertilize, hoping an embryo develops and it implants, we can see the eggs that come out. And this is done in a simple procedure. It's an ultrasound-guided needle aspiration. You do get a little medicine to make you sleepy so you don't feel any pain. And then we take the eggs out of the body. It takes only about 20 minutes. We also don't rush. We take all the time you need, but it really is a short procedure. And you're just under some light sedation, not full anesthesia. And usually you're not aware of anything going on. We take the eggs out, and then we take the sperm, whether that's from a partner or a donor, and then we can put the eggs and sperm together in the lab. There are different types of fertilization, and then that is what you will talk about with your doctor, with what that fertilization plan is, depending on the sperm. And then the embryos are created in the lab. So we can see the eggs and see the sperm and see the percent that fertilize and watch those embryos develop. And then we pick the best embryos to then be transferred to the uterus. In this way, you're increasing the chance of pregnancy because you're not only increasing the numbers, but you're also bypassing the tubes. So the success rates do depend on the age of the patient and the diagnosis. But again, we're using this for patients who have blocked tubes, very low sperm, or patients who other treatments aren't working. Again, for what we call reciprocal IVF, where one partner may use her eggs, the other may carry, and also for same-sex male couples who will use a donor egg and a gestational carrier. And also for testing of genetics. The embryos can be tested for their genetics, whether that's in general the chromosomes, is this a viable male or female, or they can be specifically tested for a condition if that condition is known. And so that's important to know, that we can't just test every embryo for every condition out there, but we have to know if you carry something and the partner carries a condition, that we can actually make a genetic test for that and test the embryo. So typically the process takes about 2 weeks. There can be some preparation time and making sure you understand how to use the medications. The medications are ordered. So typically it takes about 2 weeks to do the cycle. And then depending on whether you're going to transfer the embryo right away, which may happen 5 days after the retrieval, or if you're doing a frozen embryo transfer, that may happen in another cycle. Those are the two basic types of treatment. I always talk to my patients and say, here, these are the medical facts about what is happening. And then we also want to talk about what our patient's comfort level is with what procedure they want to go through first and what treatment they feel comfortable with. And then, of course, sometimes we may be dictated by insurance or financial issues too. So we want to talk about all those three aspects and make sure we're picking the best treatment that you feel comfortable with, and that is also either within what your insurance is allowing us to do or with what you can afford. And it's important to talk about all of those factors and making sure you're comfortable with what we do. And of course, we're all here for you to answer any questions in the office. We hope to see you soon.